Good afternoon, friends. So today we are having a very useful discussion regarding the recurrent in-stent restenosis, its pathophysiology, mechanism, diagnosis and management. So in-stent restenosis is one of the most common complications after percutaneous coronary intervention and a clinically important problem which interventional cardiologist faces daily in catheterization laboratory. So by definition, ISR is like angiographic diameter stenosis of more than 50% at the stent segment or its edges, which is almost 5 mm segment adjacent to the stent. Recurrent ISR is defined as a failure of at least 2 revascularization procedures with multi-metal layers at the stent segment. So despite the advantages of a drug-eluting stent over the bare metal stent in preventing the in-stent restenosis and target lesion failure, DES failure continues to be a clinical problem. And second generation DES have failure rates at 1 year that averages almost 6 and 9% in non-diabetic and diabetic patients respectively. So depending on the morphology of the lesion, the restenosis can be classified angiographically in different types. The type 1, which is the focal, almost 10 mm in length, and in it there is a subcategory of type 1A, 1B, 1C and 1D. So 1A, when there is a in-stent restenosis involving the articulation or a gap at the stent between the stents. When it involves the margin, it is in the 1B. When it involves a focal lesion and in the body of the stent, it is 1C, and when it is a multifocal lesion, it is 1D. Whenever the lesion is a diffuse one, it is called type 2, which is almost like 10 mm intrastent lesion. Type 3, which is a proliferative, so it is like 10 mm which is extending beyond the stent margins. And type 4 is a total occlusion, so there is a restenotic lesions with TIMI flow 0. So clinical restenosis is assessed objectively as requirement for ischemia driven repeat revascularization. So diameter stenosis of almost 50% and one of the following, which includes either a positive clinical history of recurrent angina pectoris presumably related to the target vessel, or there is objective signs of ischemia at rest in ECG changes or during exercise presumably related to the target vessel, or there is abnormal results of any invasive functional diagnostic test, that is example coronary flow velocity reserve FFR that is less than 0.8, or IVUS which shows the minimal lumen area of less than 4 and 6 for left main. It is found to correlate with abnormal FFR and need for subsequent target lesion revascularization, or target lesion revascularization with a diameter stenosis of 70% even in the absence of above ischemic sign or symptoms. It is known as clinical restenosis. So there are different patient characteristics in which the risk of ISR increases, which includes diabetic patients, patients of chronic kidney disease, patients with multivessel coronary artery disease, advanced age and female gender. So there are also certain lesion characteristics which are associated with in-stent restenosis, which include complex lesions, typically angiographic B2 or C1, calcified stenosis or CTO lesions, or longer lesion length or smaller artery diameter, or LAD coronary artery location, or ostial stenosis. And there are different technical and mechanical factors which are also contributing to the DES failure. So among the technical and mechanical factor, the major one are the geographic miss, under expansion and the stent fracture. So geographic miss occurs when the stent does not fully cover the injured or the disease segment. Typically occurs when you put 2 stents and there is a lack of overlapping segment. It is defined as geographic miss, or sometimes there is an ostial lesion and during the stent placement there is a geographic miss. Or there is under expansion occurs more frequently in calcified stenosis, and it is more frequently with early DES failure within 1 year of implantation. So this is a summary of the technical and biological mechanisms of ISR, which include primarily the neoatherosclerosis, the drug resistance, the plaque prolapse, neointimal hyperplasia, hypersensitivity, stent fracture, geographic miss and under expansion. So we can see here there are 2 images are seen. In the left sided image, that is A, that is an OCT image of the multi-layer ISR is seen with 2 layers of stent visible with neointimal tissue as well as the onion skin proliferation of neointima between the stent layers. We can see that the white dense arrows are denoting the stent strut, and the star denotes the neointimal tissue, the black star one. In the right sided image, that is a B, there is an OCT image of the calcific neoatherosclerosis, which is in stent admixed with neointimal tissue. So in this case, the red arrows denote the calcific neoatherosclerosis, while the black star denotes the neointimal tissue. This is the typically angiogram of the patient with a stent fracture. So in the left side, we can able to appreciate the fracture in the middle portion of the stent, and it is which lead to the two broken segment of the stent. And in the D, the same lesion was imaged via an OCT, and it showed that there was a stent fracture at the flexion point of an LAD and diagonal bifurcation, and there is a severe ISR1. So you can see that the yellow arrows are denoting that region where there are no stent strut are visible, which shows that there is a stent fracture. While in the white arrow in the lower 3 to 6 quadrant, you can see the stent struts. So there are depending on the mechanism of the in-stent restenosis, the potential treatment is directed. So whenever there is an unstented gap segment is there, or there is a geographic miss, typically we can go for balloon angioplasty or drug-eluting stent. Similarly, when there is a severe neointimal hyperplasia, we can go for balloon angioplasty, laser or DES. In the case of stent fracture, we can put a repeat DES or a brachytherapy. In the case of undersized stent, a high pressure balloon or scoring balloon or a larger DES can be used. Similarly, with under expansion stent, a high pressure balloon inflation scoring balloon, either laser, rotational atherectomy or DES. And when it involves more than 2 layers of stent, then either laser or brachytherapy is a reasonable choice. So multiple studies demonstrate that suboptimal MSA is the major predictor of stent failure, and IVUS optimized MSA of more than 5 or OCT optimized MSA of more than 4.5 is defined as a minimal goal for the image optimized PCI. And a more progressive approach to the image guided PCI that integrates reference vessel size is becoming the preferred strategy to preventing target lesion failure in modern practice. So using this strategy, the target is to achieve an MSA at initial stent implantation that is more than 90% of the closest proximal or distal reference segment. So in treating the ISR, it is critical to identify the presence of stent under expansion multi-layer ISR with intravascular imaging. In a series of recalcitrant ISR cases where the patients with 2 layers of DES were treated with a third DES layer, the IVUS demonstrated that the 2-layer DES under expansion was common, and severe calcification behind the stent was seen in all the cases of under expanded multi-layer DES ISR. So here there is an angiographic and IVUS correlation of a multi-layer DES ISR CTO. So you can see that in the A there is a dual injection angiography which is showing the mid RCA CTO, and the distal RCA is filled by the left collaterals. Corresponding, we can see that IVUS images are showing at the different topographic location, which is showing the multi-layer stent under expansion in the ISR CTO region. Similarly, multiple layers of stent, however, compound the ISR problem by creating an onion skin layer of neointima. It leads to crowding of the arterial lumen, it hinders the complete expansion and adversely impacts the ability to achieve an optimized final MSA. So it is a recurrent ISR is a challenging problem. There is not a consensus on optimal treatment strategy. These patients often have multiple layers of stents with a narrow lumen, which compromise if treated with an additional metal layer encroaches the already narrowed lumen. So most of these patients are also poor surgical candidates due to the prior CABG. So in here comes the role of intravascular brachytherapy. So it is a metal and drug free treatment option for this patient. It uses a low dose localized ionizing radiation to disrupt the cell cycle and prevent the vascular smooth muscle cell proliferation without affecting the healthy tissue. So it also inhibits the pro-inflammatory cell, which reduces the inflammation to the pre-existing metal layers. So coronary artery brachytherapy system available in the US, that is Novoste beta cath, utilizes a strontium 90 source to deliver the beta radiation to the ISR site, and it leads to inhibition of neointimal proliferation. And two recent studies have evaluated the efficacy of this for a recalcitrant multi-layer ISR, and it shows the TLR rates were almost 3, 12, 19 and 20% at 6 months, 1 year, 2 year and 3 year respectively. So contemporary image guided ISR treatment currently employs an algorithmic approach to vessel preparation and treatment that often utilizes the scoring and cutting balloons, laser atherectomy, rotational atherectomy, or brachytherapy, and lithotripsy balloons and drug-eluting balloons. So, the first step in this case is always an intravascular imaging to understand the mechanism of the resistance. Whenever any mechanical cause is encountered, it should be duly corrected. Stent under expansion should be treated with a high pressure balloon angioplasty and adjunctive treatment such as a laser atherectomy or a rotational atherectomy and intravascular lithotripsy with the possible use of restenting or DCB. Repeat stenting should be avoided, especially if there are 2 or more pre-existing stent layers. And if the stent under expansion cannot be corrected, or in the case of repeat DES failure, CABG is always a last resort. So, talking about the proposed algorithm, so always we have to optimize the medical therapy and control the underlying risk factors in the patient. And if the symptoms are not controlled and intervention deemed necessary, then always proceed with intravascular imaging. And if on imaging there is a stent under expansion, so in that case we can expand the stent with a high pressure balloon or cutting or scoring balloon or use of laser atherectomy or lithotripsy or rotational atherectomy. If it is expanded, then if it is not expanded because of this also, then we have to consider for either CABG or intravascular brachytherapy. If there is no stent under expansion, but if there is a stent fracture, so if there is a stent fracture, then avoid restenting, which is somewhat controversial. We can also treat it with DCB or IVBT or balloon angioplasty. And if there is no stent fracture, then one stent layer is there, you can treat it with DES. If there are 2 stent layers, we can go for a DCB or IVBT, and if there are more than 3 layers, then IVBT. And again, if there is a recurrent stenosis, then ultimately you have to consider for the surgical correction. Okay, thank you.